My name's Stuart Bergler. I'm a paramedic, firefighter. I'm the inventor of the Emergency Dermal Kit. It's a series of medical devices that improve burn care in emergency medicine. When it comes to severe burn patients, do we honestly think the current standards of care sufficiently address what both the patients and providers need? If we all know that these patients can uniquely suffer from hypothermia, fluid loss, infection, hypoperfusion, and severe physical and emotional pain, and ultimately they have some of the more protracted care plans out there, do we honestly think that gauze, loose and bulky dressing, or burn sheets directly address these symptoms? With these current standards of care, we find ourselves obligated to provide heavy doses of pain meds or sedative drugs before we can even adequately assess for critical life threats or begin the wound care process. We're not saying the current standard of care is bad for a small burn. However, in the event that we have a critical airway, breathing, circulatory concern, we can abandon wound care obligations altogether. It's too long and tedious. That exposed wound bed may not kill a patient as quickly as a tension pneumo, but it can result in a much more difficult, longer recovery plan. We invented a low-tech, straightforward solution for this problem. It can be applied in a fraction of the amount of time and all but guarantees a higher degree of insulation for hypothermia, sterility for infection, loose and bulky application for the hypoperfusion and physical and emotional pain these patients experience.
In this video tutorial, you will learn how to use the Emergency Dermal Kit on burn patients through different use case scenarios. The demonstrations will help you understand the existing standards of care and how the Emergency Dermal Kit improves upon them.
The Emergency Dermal Kit is boldly labeled on the front. It's a durable yet flexible material built to protect the integrity of the package devices inside. This is getting more important as patient care compartments in the back of ambulances are built with safety in mind, and we're losing cabinet space. The back of the kit has an adult rule of nines and a severity guide on it. I don't have data on this, but if you talk to anyone that has been in the burn unit long enough, they all have stories of emergency medical staff overstating or understating the severity of these injuries. Our guides are simply printed on the back for quick reference. We're packaging our devices in durable plastic, not Tyvek. This provides a puncture-resistant seal for devices that protect infection-prone flesh.
Before introducing each individual device within the kit, let's first introduce the patent-pending textile layering each device is composed of.
The first layer is a high-quality non-adherent. It's likely more robust than any non-adherent pad you've used before. It's gentle on sensitive flesh. Our middle layer is absorbent and it's insulating. It does a good job of moving oozing fluid away from the wound bed. Our third layer is a protective, high-strength polypropylene layer. It's still flexible, and it protects and encapsulates the sterile wound contact and the insulating absorbent layers. The interior and exterior layers are intentionally different colors. We'll get into that later. A lot of agencies are using gauze or loose and bulky dressing to treat these injury types. We think this is problematic for the following reasons. The dressings absorb oozing fluid and they park wet fabric on a hypothermia-prone patient. They are porous and allow for pathogens to pass directly through them. Porous also means temperature can dissipate more readily through the dressing. They also can be wrapped overly tight and constrict blood flow on a swelling extremity. Finally, woven cotton can enmesh itself in a wound bed and rip open when removed, further hurting the patient. Anyone that has ever had to wrap multiple digits knows how tedious and impractical this can be, though we have an obligation on longer transports to wrap each finger appropriately. This is our hand glove. The sterile, non-adherent, and absorbent layers are encapsulated by the exterior polypropylene. Let's talk about the color differences now. In order to emphasize how we want the wound contact layer to only contact affected flesh, we want providers to remember white goes to wound, blue goes to you. The military folks will get a tactical green color and will say white goes to wound, green goes to me. The idea is to provide the highest degree of sterility we can. Our hand gloves have spacious finger partitions and keep digits separated. It secures like a large mitten. It goes on in seconds, creating an immediate visual partition for your patient, bystanders, and responders not to get fixated on. It's like the concept of drapes in labor and delivery serving as a visual buffer. Unofficial internal studies at the local college showed on average it takes EMS personnel 2 minutes and 21 seconds to wrap an entire hand with 2-inch gauze. Ours applies in 21 seconds on average.
To use the hand glove on a burn patient's hand, simply remove it from its sterile packaging. Using the black grips, apply it to the hand like a glove. Secure the Velcro wraps firmly around the wrist to secure the glove in place.
If you're not initially using gauze, then you're probably using non-adherent pads. Why piecemeal a series of small, friable squares or rectangles in a non-sterile, slow fashion that still ultimately require gauze wrap when you can isolate and protect an injury in seconds with a cohesive, non-adherent layer device? All of our devices are built to accommodate adult patients 6'4" and shorter. They're more elongated on taller patients. They're more compressed on shorter patients. Let's discuss this wound care approach with regards to chemical burns. If you're a supervisor on the civilian or military side, do you want your medics piecemealing non-adherent pads together one by one and then wrapping their hands over and over around some affected anatomy like we showed with the hand and arm and likely being exposed to cross-contamination themselves? Or do you want them to be able to isolate and protect that extremity like this?
Gently slide the sleeve onto the patient's arm as shown. Make sure the sleeve reaches the patient's shoulder before securing it in place. Pull the drawstring at the top of the sleeve first, then adjust the sleeve so the bottom drawstring can be pulled securely around the patient's wrist.
It encases the entirety of an injured arm from shoulder to wrist so that whatever material she has on her isn't all but guaranteed to transfer onto your staff. If medics lose our tactile abilities, then we basically lose the ability to work altogether. We wanted radial pulse access left open between the sleeve and glove for monitoring purposes. We built the arm sleeve with IV, IM, and vital sign access, but suggest you collect vital signs and provide interventions elsewhere if you can. Preliminary studies at the local college suggest on average it takes 1 minute and 21 seconds to wrap an entire arm with 3 or 4 inch gauze. Ours applies in 16 seconds on average. Now we all know burns are caused by heat. But when you remove all that heat, what happens? Water-soaked dressings are appropriate for small burns, providing cooling, pain relief in a square package like a non-adherent pad. However, with prolonged use in a large burn area, these water-soaked dressings pose a real risk of hypothermia to these patients. As more EMS protocols have gotten away from cold dressings altogether or limited them considerably, we recognize the need for an insulating, loose and bulky, non-adherent, sterile device is becoming more important in our industry. We're not saying topical ointments or cool dressings are always bad, just that for people with large burn areas, it can be dangerous, and the Emergency Dermal Kit addresses that. Our obligation to isolate and protect these wounds and get them to definitive care with as minimal topical interaction as we can possibly provide. Unofficial internal studies at the local college showed on average it takes EMS personnel 2 minutes and 8 seconds to wrap an entire leg with 4-inch gauze. Ours applies in 23 seconds on average.
Using the black grips, gently slide it onto the patient's leg, as shown. Make sure the pant leg is pulled up as high as possible on the leg. Next, push any extra material up from the bottom so the lower drawstring securely fastens around the patient's ankle. Note, there is no drawstring at the top of the pant leg, as the lower drawstring solely keeps the pant leg in place.
When it comes to abdomen, thorax, posterior neck burns, we find ourselves pretty limited with wound care devices. Probably the most popular is a sterile burn sheet applied to the cot and one placed atop the patient's body. Anyone who has done their fair share of truck checks over the years can confirm that most of these devices, stuffed in Tyvek packaging, have their sterility compromised when that packaging is ripped open well before we're dispatched to that burn incident. We then take a thin, friable, non-insulating 60 by 90 inch sheet, possibly place one on the cot for sterility, and then crudely wrap a second one around a patient head to toe. And we're basically wrapping any contaminant internally with that patient. These don't insulate at all, and they don't allow for access to unaffected flesh for medication administration, vital sign collection, and so forth. Instead, we wanted to include 3 devices for this neglected anatomy. We have a sterile cot sheet that fits over any EMS stretcher in every kit. We all know that the linen racks at the emergency room aren't remotely clean. Our devices are sterilized. After that, we have a torso blanket, which is nothing but a glorified Chuck's pad. It's simply sterilized and thicker for insulation purposes. White goes to wound and blue goes to you. With regards to neck burns, we built a neck gaiter with the same textile assembly. The neck gaiter may strike some people as silly, but what are we currently doing for these burn patients? Circumferentially wrapping loose and bulky dressing around their necks, administering pain medication and sedative medication so heavily that if we find ourselves in a position where we're considering a surgical airway, or we need further airway assessment, we then have to unwrap 6 feet of wound wrap from around an obtunded patient's head or trauma shear it off, leaving fibers everywhere. While our neck gaiters are sterile, insulating, loose and bulky dressings, you can secure together or take off easily enough.
Just like the other items in the Emergency Dermal Kit, the cot sheet, torso blanket, and neck gaiter are all wrapped in durable plastic, maintaining sterility until opened. The specific use of these devices depends on the circumstance and providers and patient's needs. Emergency Dermal Solutions understands the nature of burn wounds varies greatly, and these items strive to provide options that offer the same care as the more specific items in the kit.
The unique shape of craniums and feet led us to employ standard wraps to treat burns. Preform anatomical wraps were not practical for this anatomy. We have 1.5-inch and 3-inch wide wraps that are 6 feet in length for this more difficult anatomy. All I'll say is if you have to wrap it, have a strip of 1-inch tape around to secure it in place. Burn patients suffer complex wounds that require protracted stays in burn units. Our current standards of care don't cut it. The Emergency Dermal Kit's devices allow a provider to treat disfigured wounds quickly without compromising patient comfort in the process, setting up the patient for success and healing. No fumbling around in a protocol book, just intuitive devices that are panicking provider-proof. Our company is Emergency Dermal Solutions. We take pride in simplifying and expediting patient care.
Thank you for watching this video tutorial of the Emergency Dermal Kit. To reach out to Emergency Dermal Solutions for assistance, please visit edsmedtech.com.